CT scans are powerful tools for children, but they carry a serious question about safety. A child's body is far more sensitive to radiation, magnifying the long-term dangers. Though they're just 12% of procedures, CT scans deliver nearly half our total medical radiation. Studies directly link this childhood exposure to higher risks of leukemia and brain tumors. How big is this risk, and can new tech make these scans safe? We'll break down the verdict. So let's quantify this. The risk from one scan is small, but the real danger is cumulative exposure. Science has identified a specific danger threshold. A cumulative dose of 50 to 60 milligrays is the line. That dose, from just a few head scans, can nearly triple the lifetime risk for brain tumors or leukemia. In response, the medical community created a guiding principle, ALARA, or as low as reasonably achievable. First, ALARA means you never use adult settings. Protocols are adjusted for a child's size to slash the dose. Second, don't scan what isn't needed. That's why targeted imaging has replaced routine full-body trauma scans. But radiation is only half the problem. Many scans need an injectable dye called contrast. A child's body isn't a miniature adult. Different physiology means adult contrast protocols can be dangerous. This delicate process demands that a supervising physician be immediately available to manage any adverse reaction. But with radiologist shortages, how can every child get that oversight? A technology called virtual supervision aims to fix this. An expert radiologist oversees the scan from miles away through real-time, high-definition connections. This isn't theory, it's a federally approved practice, greenlit by the Centers for Medicare and Medicaid. Safety is maintained through a qualified on-site technologist, who acts as the radiologist's hands. The remote expert supervises, but the local team must be fully equipped to handle any emergency on their own. So, virtual tech helps solve the access problem. But can technology also attack the radiation problem directly? Absolutely. The biggest breakthrough is in the image building software, using deep learning reconstruction algorithms. These algorithms create a high-quality image from a low-dose scan, massively reducing radiation exposure. The tech gets smarter. What if you could get two images, with and without contrast, from a single scan? That's virtual non-contrast, or VNC. It digitally removes contrast to create a before image, sparing a second scan. But this tool has a critical flaw. It struggles to measure bone density accurately, risking dangerous miscalculations in radiation therapy. Adding another wrinkle, some data suggests VNC might work better in kids than adults, showing there's no one-size-fits-all rule. We have incredible tools that slash radiation and expand access, but they bring new risks. So how do you decide? This brings us back to ALARA. Today it means intelligently choosing the right tool, like knowing when VNC is unsafe. And a child's unique physiology is why virtual supervision is about more than cameras. It's about applying pediatric-specific knowledge remotely. True safety is an ecosystem, justifying every scan, using the lowest dose, and having expert oversight, virtual or not. And the safest dose is 0. When possible, MRI or ultrasound should be used. A CT is a last resort, not a first choice. So, are pediatric CTs with virtual technology safe? The answer isn't a simple yes. The scans carry a real, measurable risk. They are safe only when managed in a rigorous culture of safety, with pediatric expertise guiding every single step. For parents, this means asking two questions. Is this scan absolutely necessary, and how are you minimizing the dose? For medical professionals, it's a mandate to question everything, adopt technology wisely, and always image gently.